easiest way to do it. All right, folks, welcome. Tien Phung, welcome to Tim Talk.
Hi, everyone. Thank you for tuning in and welcome to my home.
So this is awesome being in your home. I've never had a spread like this. We have food. We have mimosas, which
Cheers.
Rosemary, I don't know if you're watching, but Rosemary had suggested doing this for episode 1, but this is, I've never had such amazing treatment. And for an Italian, some mimosa, some nice cheeses and nuts. Yeah, this is a great way to start it up. So anyway, thank you for letting all of us into your home.
And thank you for having me. This is quite exciting. My first talk show.
Yeah? This is your first time doing anything like this?
Yes, absolutely.
Yeah.
I'm, pretty private, but I'm passionate about this industry. So I'm happy to be here to.
I remember when we first met, we went out, grabbed a lunch.
Yes.
And my first impression was like, you and I are such opposites. Like, I love you and I love, I'm looking forward to the future of working with you and stuff like that. But it's, I'm like super extroverted.
Yeah.
I'm on like, the more attention I can get on social media, the better. And you're just like, I'm not on socials.
Nope.
I just do my own thing. Reserved, quiet, and just getting business done. So it's great to have you here. I think the thing that most attracted me to you is that, just like a lot of the folks that we've had on Tim Talk so far, is that you're extremely responsible in healthcare. I'm sure a lot of that comes from your nursing background, which we'll talk about. But I love aligning myself with folks that are not exploiting patients, exploiting the system, or just being bad actors. As most of the people here know, I like to call them out a lot. And every industry has them. I mean, even in, we're going to talk a lot about home health, but, it's really difficult because some people, you've heard of white coat syndrome, right? Where they're meeting with a doctor and they almost seem godlike if you don't work with doctors. Once you work with enough doctors, that opinion goes way to the side. And I think that it's I don't know, a lot of people put a lot of stock in what it is that they say and don't realize that doctors are just like anybody else. Some of them do have huge egos, like their reputation usually is. Some of them are very practical people, very nice people. I had this surgeon client before who was also a farmer on the side. And, people are just people. They all have their different things that they do. And, and even in home health, I was researching, there were some folks who I saw that, they're experiencing what I'm calling the operational squeeze, which is why I think you are so perfect to be coming up at a time like this. I think home health needs someone like you and other folks like you right now more than ever, because operationally is where the pinch really is. But, it's leading, I feel like the staffing turnover, the difficulty in procuring reimbursement, the regulatory side. Not that I would ever excuse somebody for being a bad actor in the system, but does it lead to people who are trying to see more patients, falsify documents? And I don't know why Florida is always on this list, but you have Florida, Texas, and California right now are the big culprits I've seen in home health when I was doing my research to prepare for this. And so it's always sad to see things like that on the clinical side, to make sure folks are aware of things that are going on. But I really actually want to talk about you first, but we're going to get back to you. Can you tell us about what the current climate is for home health, what the pain points are, and why it's so difficult for people who are navigating that right now?
Sure. And to talk about the bad actors, I think it's difficult to say because the system is so complex to provide care, especially with clients now or individuals. We're dealing with the baby boom population, and you're also dealing with just the complexities of the care needs. And also our current care infrastructure, in my experience, is very fragmented.
Okay.
So I just think that the majority of our providers are trying their best, in my experience in working with them, to navigate through the complexities of the post-acute care settings.
So take us into that. So you're talking about the complexity of a patient. And I think if someone's, if you have like a 24-year-old with pneumonia, it's not really a complex case 99% of the time. But when somebody is, let's say, in their 60s or 70s and they have pneumonia, it becomes significantly much more complicated. I think in acute hospitals, it's about a 10% death rate for folks getting admitted into the hospital with pneumonia, those age ranges, because they might have all sorts of comorbidities and different issues going on. So what are typical patients in home care? Like what if you don't mind letting the audience know, what establishes somebody for being medically necessary to receive home health care, and what are they typically suffering from?
So there are various branches of home health care entities out there. So we could there's home care that specializes in pediatrics, and then there's home care that specializes in adult care. So adult care is anywhere between 18 and older. Where we find challenges are managing clients that are of the senior population, older, with multiple comorbidities. And we discussed before that a lot of home health organizations do not have a comprehensive, holistic program to treat an individual. Right. So then oftentimes you're finding that a client would need to have multiple home health support, different agencies that they have to manage and navigate through, because just to augment the care that's needed.
And why is that? Why is it that home health services don't have that bandwidth of complexity to be able to manage multiple issues?
Funding.
And what is that funding? And that funding is all mostly state and federal government, right?
Yes, and also payer reimbursement. It doesn't have to be even state or government funding. It's payers, like private pay as well. Insurance companies that are private pay. So there needs to be a medical necessity. What
does that mean? Like basically, so for medical
skill need.
Yeah.
So what makes a client eligible for home health services is that they need to be homebound. Is primarily, one of the criteria, because if they're not homebound, then technically they can receive the treatments elsewhere. Care outpatient. They can drive themselves. They're stable enough to go and receive the care, in the outpatient setting versus in their homes.
Right. And the main requirement there is so that the federal government doesn't have to pay for such visits. If someone's able to drive themselves, then they should be in all theory able to get outpatient care from a private practice or something like that. And
that's the most optimal ideal situation. But there are some clients that either don't have the physical ability due to their condition, the medical condition, or if they're in rural areas and they don't have access to care, right? They don't have family support or if they have mental health disorders that cause their ability to function and manage their own health. Right. So we provide care to address those needs.
Yeah, because in rural areas too, you could have a need for a certain kind of specialist that there might not be access to either.
Absolutely.
Like I remember, but I used to do a lot of work over at Haywood Hospital up in Gardner, and it's so funny because you go into the middle of Massachusetts and you go from just like this hustle and bustle to a very different, like it feels like what I picture, a lot of communities in the South to be, much more spread apart. And folks who work at Haywood Hospital, last I checked, I haven't actually been there for a few years, had to be very much like leadership driven type of folks. Like if you were I did a lot of stuff with the hospitalists there, did some wound care stuff, but they would do, they didn't have a nephrologist there. And maybe they do now, I don't know. But like they didn't have certain subspecialties that in most acute care hospitals we assume are going to be there. So if you're a hospitalist there, you better know a whole, you're not going to really get a lot of hand holding. You have to be able to take on a lot on your own. So, I mean, is home health kind of like the Wild West in that way, where it's, there's going to be a lot asked of you that that a certain type of clinician is not going to be really equipped to manage. And I'm sure you have to sub a lot of that stuff out. But in a typical day, you guys are driving all over the place.
Yep.
With, I don't know what I imagine some of the equipment in your vehicle some things might even have to be held at a certain temperature. I don't even know. Can you give us a little picture of what that's like?
Sure. So imagine you are in, let's say, a hospital setting in a medical surgical unit, right? And you're treating a client. The difference in that setting is that you have access to your doctors, you have access to your interdisciplinary care teams, your nurses, your physical therapists, respiratory therapists, wound specialists, lab technicians.
And they're all right there.
They're right there,
Yeah.
right? Supplies, and you have access to IT support if there's any issues with your technology.
Mm-hmm.
So that same level of care, you take that and you translate it over to the home health setting.
Because that's the expectation.
That is the expectation.
Okay.
Where we're treating high skill level clients that require extensive wound care, wound vacs, IV therapy, PICC line management, vents, trach care. So,
but you guys are going alone to these sites most of the time, right?
Yes, yes, and navigating, traffic and road closures, trying to find parking that you're not going to get towed, and then going into the home not knowing what to expect, and not having the supplies. Clinicians will then have to MacGyver it and trying to figure out, how to
duct tape and bubble gum basically to get things.
Yeah.
Yeah, and I imagine sometimes too you have combative patients or difficult, like, I mean, you walk into some places and it's like probably filled with cigarette smoke or something like that, and you have
or pets or dogs and infestations of
like mold or mice or things like that. Oh, that sounds like a lot of fun.
Oh,
so everyone's signing up to do this, I imagine, right?
Well, that's the thing. I don't think that I think that there's a gap in administrative teams and the clinical field teams, and not really understanding or recognizing the complexities of field operations. I have appreciation for it because I started in the field and was able to appreciate the challenges. And so when I transitioned over to management, I did my very best to make sure that field ops was prioritized and making sure the assignments were logistically manageable, and trying to set up the cases so that our clinicians just go in there and execute, trying to do everything we can to support our field teams.
So let's talk about that. Now that's a perfect segue. So let's get into your time as an RN. So you have your master's in nursing.
Yes.
And you spent, how much time did you actually spend in the field?
So prior to home health, I was working as my first nursing position was actually at a jail, at Essex County Correctional Facility.
So you've always had a taste.
Abby, if you're watching.
You've always had a taste for the challenging
Well,
environments.
you know what? I'm not from Massachusetts, so I'm from California, and I went to college in Pennsylvania.
Okay.
So I moved out to Massachusetts. So I didn't really know the systems and where to apply.
Okay.
So I just applied everywhere. And my first interview was at when I applied, it was labeled as a medical unit. So when I went to the interview, I called my director and said, I'm sorry, I'm going to be late. My GPS brought me to a jail. And so I'm going to be late. She said, oh, no, you're in the right place. We're a medical unit located inside a jail. So I was like, you know what? I'm already here. I'm going to go straight to the interview.
Yeah.
And, I was fascinated with treating the population, the inmate population, and learning that the majority of that population are in there because of mental health, substance abuse disorders.
Yeah. Yep.
So that was my first nursing job in Massachusetts. They didn't think I was going to last there when I first came.
I wouldn't imagine most people would, yeah.
But I managed to stay there, and for a year as a charge nurse, third shift, and learned a lot. Then I transitioned over to occupational health. So I worked for Health Advocate, where we went to corporate organizations to screen, promote health, screen for BMI, cholesterol, blood pressure, to promote health in the businesses, which I really loved. And I discovered early on that I enjoyed promoting health and preventing disease and educating, versus being in an acute setting where we're managing the disease that's already exacerbated, right? And I didn't want for clients to get to that point, right? So
I see where a lot of this is going to carry over, but go ahead.
Yes.
Yeah.
So then I found that I had a passion for the underserved population, mental health, substance abuse, dealing with vulnerable populations. And I was pursuing higher education at the time. So I took a position as a home health nurse, Baylor nurse. My first home health position was at Suburban Home Health.
Okay.
And then I thought it was very interesting that we were going, I didn't even know what home health was at the time.
Yeah.
And I didn't realize that we can treat clients in the home setting, which I found was invaluable because you're able to see what resources our clients had, what they didn't have, if they're really adhering to the plan of care or the treatment regimen that's prescribed.
If the patients are adhering to it, yes, I'm
because
sure
you can just open up the fridge and then see, okay,
right. Oh my God, that's probably like a lot of clinicians' dreams, where the PCPs are probably standing there like, you're full of it. Like, I know that you're not doing what you're saying you're doing in this meeting, but you actually have direct access.
Absolutely,
to it.
we're the eyes and ears of the providers, and you know, what's interesting is when you're in a controlled environment, the client can say whatever, right? And I'm adhering to this, I'm taking this and that. But when you're going into the home setting, you're saying, okay, they don't have any of the medications in there. They're counting the medications, and we still have like 5 or 6 medications left over. So we can really be impactful in coordinating that care and facilitating.
So what do you do in those situations? Do you have conversations with the patient and just call them out for their...
Yes.
Okay.
Just like, what are your barriers? And I see here that you're not taking the medications as prescribed. What are the challenges? Are there any side effects? What are your concerns? And trying to understand the reason why first, right?
That's interesting. So you get your master's after this, or concurrent with this?
And then when I was working as a Baylor nurse and I did mostly admissions, I realized I was sent from point A to point Z all over the place in Massachusetts. And I was like, what the heck is going on? Right? Because why am I live out in Tewksbury. I've been sent all the way up in the Essex County, all the way down to Suffolk County. I was like, there's got to be a better way to manage this because it's not the most effective use of my time. Then as I'm traveling, that could be time that could be used to document, you know, this extensive OASIS documentation. Yeah. And so I'm a very inquisitive person. So I like to figure out why things are happening. Right. So when a leadership opportunity opened, I took it as, you know, clinical manager. And I wanted to learn more about home health operations and wanted to understand more as to what's the scheduling process, what, you know, why are we being sent all over the place? And then I learned after I went into management, the complexities and the amount of effort and coordination, collaboration, and
everything's so different when you look under the hood of any operation.
Oh, absolutely. I have a better appreciation for management.
Yeah, me hearing you bouncing all around the place, I'm like, what, were you the only nurse that they had? Because if they have 50 nurses, why don't they section you to this region and blah, 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 blah. So it's not as easy as that, is it?
No, it's that, but also I think with scheduling, logistics management is really critical. And I think in my experience in working with various organizations that there's a lack of understanding with that, because again, they're not in the field. So unless you're in field ops and you're going to see clients, a scheduler would not, unless they've been doing it for a long time. Yeah. It's really rare to find good schedulers, and it's one of the most important roles in home health. Is having a strong scheduling team to understand the logistics. And ideally, we would love to have that in an EMR systems that would, now with AI technology,
to be able to
EMR systems that would manage,
make that much more efficient
logistics.
Now, when you're doing home care, I can't imagine the schedule is as tight as it would be at a traditional office, where you have an appointment at 8, an appointment at 8:30, an appointment at 9. I mean, like, you're traveling, there's going to be traffic. Like you said, you're going to have to fill up your gas tank at some point. So, I mean, is it more of you have to see these 8 patients today and get them all done at some point, and you try to give the patient a heads up of ETA? Like, how does that actually work?
That's the goal, ideally. And that's the thing about home health, is that you have to be fluid, flexible, and be able to pivot at the last minute, because how you manage your assignment, your schedule, depends on the priority or the level of care that's needed. So for example, if I have to travel to, let's say, Woburn, right? I've got clients scattered all over the place, even though I may have a client that's next to my home, but let's say they're exacerbating or experiencing some sort of medical urgency. You obviously have to prioritize that client first.
Right.
And then you also have to plan your schedule around, prioritizing admissions, because that takes longer. Also, certain types of skill need, like for example, wounds, and then coordinating that with the clients because they have their own lives as well.
Right.
Ideally, they're homebound, so they should not be out and about too much. But
the reality
is, some of these clients, they're complex, so they have multiple doctor's appointments, right?
Okay.
So
I'm sure there's also mundane issues too. Like they're probably at sometimes like, oh, I got to go get my groceries, and then you guys show up there at that time, and
so think about 8 clients, 8 different variables, possibilities that you would have to consider, and that's just the client itself and managing.
So who in their right mind gets into operations for something this chaotic? Because, well, I mean, I imagine someone who's so because so you seem to be very much of the mindset of like a traditional ops type of a person. Like you very much seem to be. So this, like going to prison for your first job, seems to be, that came out terribly also, but that, this is going to be a tough beast to tame. Like this is going to be a massive challenge. And so you get into operations really is, well, hold on. So you start in management, but your management job sounds very much like an operations job, really, like scheduling, and that's all your day-to-day stuff to make sure you're coordinating everything, dealing with problems that everybody has. The folks in the field are going to be calling you. You're going to understand what they're going through, or if they're full of it, you can just tell them like, hey, tough luck or something like that. But
well, it's helpful now with EVV.
With what?
EVV.
EVV?
No. Electronic visit verification.
No.
So EVV, it helps to reduce visit fraud because it requires GPS locators where we can track our clinicians. To time in and time out to make sure that they're at the visit, and that then we can also determine, looking at the visit type, to see how long does it really take to see a particular client. I think that's helpful. I mean, it is another operational challenge to EVV now that's due to the CARES Act, to manage that, because it's another operational challenge, the bandwidth that's dedicated to just manage EVV errors that we would have to fix. Right. And then there's technical issues and glitches that clinicians are experiencing in the field.
Right.
And already, so we talked about the complexities of providing care in the home setting on top of the IT challenges. So that
where you're not on the med surge floor, you don't have all these folks where you can just pick up a phone and call IT.
Yeah. And then if they're not clocking in and clocking out, they can't open up their next visit. So imagine the frustrations of our clinicians, and that, or
being at the patient's home and not being able to actually document anything, treat it,
and that's
bring up
one
their
of
history.
The causes of turnover is due to the demand, the demand of the workload that's required.
So staffing is a real pain in this whole environment, right? So folks burn out quick, I imagine.
Yes, and it's not just for
excuse me,
not for field clinicians only, but also an administrative leadership department as well. Because it's when they don't have the staffing to cover, if we don't have staff to cover the client needs, then the pressure's on in terms of operators' ability to meet operational metrics, right? Yeah. Which ultimately determines the health of an organization, is based on the metrics. So it's a vicious cycle.
Right. And so we'll get into that vicious cycle, I think, maybe right now. So so all these things are happening where there's, we haven't really gotten into the regulatory red tape piece here. We haven't talked much about OASIS yet. And the documentation requirements that your folks have, because most people, what they see is they'll see somebody comes into their house, they treat them, they leave. So easy, right? But the reality of the industry is very different. The way you get paid is, it's not like you're going into Target and you're buying a set of kitchenware, like some forks or something. To get paid, what do you need to do to get paid?
Well, there are several requirements. You need a face-to-face. You need to make sure that there is a skill need.
Yep.
the client wants services and that we can accommodate the services. Then once a client is admitted, we want to make sure that the documentations are filled out.
It's counted as an admission once you take on a client.
Yes.
In this field. Okay.
Yes. So once the client gets admitted, we have to complete documentation called the OASIS documentation, which is a comprehensive assessment, and it helps with billing,
like a history.
Yes, and depending on how it's scored, will determine the reimbursement as well.
So
the acuity
the
level.
more acute the diagnosis,
Yes.
or the more complex the comorbidities or whatever it is, the higher the reimbursement.
Correct. But it also depends on which episode they're coming in as well. So let's say,
Meaning what they're being treated for?
well, no, I mean, let's say that there's a frequent flyer, meaning that's a term that we call
Yep.
for clients just coming,
You see a lot.
you know, revolving door, come back into home health services. So there's early episode billing and there's late episode billing.
Okay.
So if a client gets admitted back into our service within that time frame as the late episode, then the reimbursement is less.
So you, just so I understand this, you have a patient that gets admitted for COPD. When you start treating that patient, it's going to be more complex. Your staff's job is to stabilize that, make that better controlled.
Yes.
It gets better controlled. The diagnosis stays the same, but the work is less medical decision-making involved. There's the visits are probably going to be shorter as long as the patient is progressing as expected.
That's the goal.
Okay.
Because
so now patients that don't take their medication, patients that aren't progressing, maybe there was a misdiagnosis, maybe there's a comorbidity you weren't aware of, they were suffering from something else, and you have to reassess. Are you able to keep that? Is there some way to indicate on OASIS that that is still a complex case and it has not turned into something more predictable?
Yeah, well, I mean, you have to do what's best for the client and document really what their true status is.
Yeah.
Right. So the goal is, as the client stays on us, the goal is that they're stabilizing and the frequencies, we're tapering off and we're reducing the visit frequency and making sure that they're able to retain and recall all of the teachings that were provided and adhering to their care plan. And then we do a safe discharge. Okay. That's the goal. Yep. Because in order to receive home health services, it's really intermittent. It should be that it's intermittent skilled care. That we're expecting improvement.
Yeah.
Otherwise, if it's not, we have to really evaluate and determine what's the prognosis and would it be appropriate then to transition? Yeah, would it be appropriate then to transition a client to palliative, hospice?
Yeah.
And the goal is to transition clients sooner to palliative and hospice to ensure, care continuity.
Right. Interesting.
Because you get reimbursed differently in different care continuums.
Right. So, wow, that's really interesting. So basically, if the patient is homebound, but requires care that you think is not going to be ending, let's say they have something that's really like Parkinson's or something like that, that's going to be long-term debilitative type of prognosis for them, they're going to need constant care for whatever reason, then they're probably a better candidate to go to a skilled nursing facility.
Yes.
And you have to effectuate that transition from, you guys might be there in the very beginning, but then you guys, once you make that assessment, they can't be long-term. Is there like a certain threshold that you have to go through where you can't really be treating the same patient for more than 6 months or something like that?
It's really case-by-case basis. And that's why we have to do case conferences. And it's really tailored to individuals. It's not one case is the same,
Right.
And that's the complexities of the care that we deal with.
Yeah. And that's the thing too. I mean, with a lot of the work I've done with like adult medicine, especially in the hospitals, it was like, to go back to the pneumonia example I gave before, it's treated almost identically for people who are young. And for older people, depending on, you got to look at what their current medications are, make sure that however it is that you're going to treat this patient, it's not going to conflict with what their particular situation is. And therefore it becomes a higher level of decision making, more difficult to assess, and much more complex to manage, and becomes an individual. Like,
and then the metabolism changes as well as we age.
Yeah.
So, as we age, our ability to metabolize medications are different as well.
Yeah.
Some people can be more sensitive to medication, some require more. So it's really tapering and tailoring the medication regimen to the individual needs.
Interesting.
So,
Okay.
so that is why it's so complex, is because it's not a one size fit all.
Right.
Although the infrastructure that we need to establish is still facilitating that care, having some sort of framework, right, and a process to identify different care needs to ensure optimal outcomes, and that's what's challenging in this industry.
And who authorizes? So although it has to meet medical decision making or medical necessity, I'm sorry, who's authorizing this service? Like, so is it usually the patient's PCP? Like, is it primary care that says, hey, I have a patient that needs your services? Is it usually from a hospital, mix of them?
So we get referrals through, yes, a variety of care entities. It could be from the acute sector that is referring to us. Could be from post-acute primary care or specialty providers.
Okay.
Could also be family or patients looking for care.
To determine if they qualify?
Well, they'll just call and say, hey, we need help. And we can then tell them this is what they need to do. They need to go and get a doctor's visit. And we need a primary diagnosis to justify the need or necessity for care.
Yep.
And we need that document. It's called a face-to-face, and which justifies and certifies that care is needed. So without that document or orders to initiate care from a provider, we can't provide care.
Okay. And also for the folks at home, if you have any questions, I don't know, we don't usually get a lot of questions here, so I don't know if the actual thing works or not, but if you have any questions, whether you're watching on YouTube or more likely LinkedIn, you can feel free to throw them in. I'll get to them when I notice them, which is not going to be necessarily immediately, but if you have any questions, I don't care if you're like a patient, somebody that's already in the field, or even if you know Tien, go ahead and reach out. So so what you're painting is a picture here that is a very complex environment, especially from the operational side. It seems like that, I mean, as difficult as it is clinically, and it seems very difficult because most of the folks that are doing the work are going to be nurses, PT, and occupational
therapy. Occupational therapists, medical social workers, speech therapist,
and what I've noticed
nutritionist,
too,
ideally, and a psych nurse would be just amazing.
Oh, I want to get into the nutrition thing too. But, I know on the medical side, 4 out of every 5 nurses are female. Is it similar in like PT and OT and like a therapist? Do they tend to be one gender or the other? And the reason I bring this up, I can see you're kind of like, where's he go with it? Is that from a safety standpoint, like someone going into someone else's home, I would imagine it, not that I'm trying to dissuade anyone because I know you guys need as many people as you can get right now, but there has to be a bit of an unnerving effect. Like you, every single time, like they say, like I have some friends of mine who are police officers, let's say, and, I don't know if you've ever noticed this, but if they pull somebody over, when they're walking up to the vehicle, they put their fingerprints on the back of the vehicle every time when they're approaching the driver's side, because if anything happens, they can establish that they were with that vehicle at that time. And then they go and they typically come up with, a lot of them are trained to be very aggressive to control the situation because they have no idea when that window comes down if they're going to see the barrel of a gun, if they're, who they're pulling over, right? Not that we're at the same intensity level there, but in a way,
we are.
Because you don't know what's on the other side of that door.
Yes, and I mean, for clinicians to work in the home health setting, they have to go through extensive background checks and CORI checks. But going into clients' homes, we don't have the ability to conduct a background check, right?
Right.
So yes, there is exposure and risk. However, we do receive clinical the system is actually, when we get referrals, are great at documenting also any type of safety risks or concerns, which the intake team usually screens for and alerts management, at which
Okay.
point we would coordinate safety protocols. So, for example, we would send out another manager.
Mhm.
We would not let any clinician go out if they feel that their safety is compromised. We would make sure that they're having 2 people to go, or we can even request, police escort. We've done that as well.
Interesting.
And they do provide that level of support to our visiting nurses.
Is there some way for them to send an alert if they're surprised by it? So they go inside of the home and then something happens? Is there some way for them to reach out?
Clinicians should not approach if they feel
as soon as they get a sense.
Yes,
exit.
then just exit. Just say I have to take a call.
I guess in that way, it's good that the patients are homebound because maybe they can't give chase that well, right?
No.
Okay. No, it's weird. It's just like a thing because I mean, were there times that you went into a home like that you felt worried at all about this stuff? Or
so one of the protocols that we implemented is we screen the clients prior to try conducting the visit. So we'll do a welcome call where we would ask questions for: do you have pets? Do you have guns or weapons in the homes? If you do, you would need to secure them. We would let the team know. They'll conduct, joint visits at that point. So we implement.
That's smart. I would definitely need to secure my dogs.
Ideally, I would love for us to be able to fund to have some sort of alert.
Yeah, something where it can be a simple
just like,
touch and hold type
alerts
of thing.
For our senior population.
Yeah.
Just so that we can press automatically.
Right. I think that would be great. So let's get into what you want to talk. I mean, that was just the drama that I was just kind of spun into there, but let's get to your stuff here. So you were just bringing up nutrition. So before we jumped on here, and then I want to get into NuOps after that. I think, God, we are flying in time here.
Are we? How long have we been?
We're already 37 minutes in, but it's okay. It's okay. We'll get to everything. Let's talk about preventative care and why you just brought up nutrition. I mean, is this a good plate to be serving me here? Can I eat all this right now?
Oh, you can't eat all of it right now. I think everything in moderation is good.
Fine, Tien.
Well, the goal is to save costs. Really, the objective should be, health promotion, disease prevention, and that's the core foundations of nursing.
Right.
We took an oath, and that's one of the foundations of nursing is to prevent disease exacerbation, right? Through education and improving health literacy. That's one of the challenges that we have to navigate through is the health literacy. Not, we've gone through years of training. Some of the medical conditions, medications are complex.
Right.
And how do we communicate that to individuals without, high level of education? And that's predominantly the situation, because then we're dealing with low income families as well that, because they don't have the funding or resources to have proper nutrition or good foods or access to.
Which is weird because Americans, I feel like, are super nutritious and very educated on nutrition, don't you? No obesity epidemic here. But so I guess the question is then, I'm not going to say by the time you're working with folks that it's too late, but because I'm sure it's never too late. Whenever you can instrumentally change things, it could at times maybe dramatically help people's conditions. Like folks with heart disease being able to even just take simple walks and stuff probably make a significant difference in changing their diet. But reactive is one thing and proactive is another. If you could have it your way, if you had your little like Mary Poppins wand, except for healthcare, how could you clean this mess up? Like what do you think would be a good opportunity to improve nutrition education? Because I've never seen, unless you're seeking it out, how did you become educated in nutrition, and what do you think would be a good solve for like the US when it comes to that?
Well, I recall just going through receiving education in the United States. I didn't take a course on nutrition until I was in my nursing program. So courses in nutrition is not offered to the general school.
Right. Like high school would be fantastic for something like that, right?
But although I am now aware that they're starting to promote healthier meals in the school systems in terms of what they're serving in cafeterias.
My school, I went to Stoughton High School. Boom, calling them out on this one. Big risk for me to call them out. They had their burgers. I once saw the boxes. It said grade E, but edible. I'm telling you the truth. And like school food, it was just it was like these old rotten burgers. It was like just pizza. There was just garbage there. So, I mean, I know that the president's doing some or the health secretary is doing some Make America Healthy Again, bring back like the presidential exercise test. But I think ultimately what I've seen as a non-nutritionist is diet is so much more important than exercise, where it's great to promote exercise and we should do that. And I think that's a great thing that's being done. But, you know, having a requirement of at least one semester in middle school, maybe even, you know, in nutrition, so people understand what the actual definitions are of a carb, a protein, a fat, a calorie, like even just those 4 terms, really understanding that probably would go a long way. I see you not agree with that.
I agree with it.
Okay.
I completely agree. I would even take it a step further and make it a requirement for everybody to take at least 1 year of a nursing program, LPN programs, just so they can learn how to take care of themselves and their families.
Right.
You know?
I totally. I mean, how often do we need first aid? I mean, constantly. Like any little thing that happens where you can even know basic first aid can really change a lot as well from just people's day-to-day life. I mean, like the CPR programs and things like that. I mean, those are like what, a 2-hour course.
But you know, it's rare to find a home health organization that has comprehensive clinical programs that addresses clients' needs holistically.
Now, I bet you at home know why, but why don't you let us know? Why is that?
Well, it costs money to fund these programs. And so you often don't see strong clinical programs in the for-profit sector. Some of the strongest clinical programs I've seen are with nonprofit organizations like All Care VNA and Hope Health. They've got strong clinical programs where, you know, like I said, All Care VNA has a comprehensive service line. They have throughout the care continuum. So, for example, they have skilled nursing. They also have private duty, home health, which provides companionship, private personal care for clients that have functional deficits. And then they have a palliative program and then a hospice program. They also have nutrition. They have nutritionist clinicians at that time. And I just thought that this was the model, you know, everywhere.
I mean, it sounds beautiful.
It was great. And but it's not the case. But, you know, All Care VNA has been established for over 100 years. So
they're massive. So this is where we get to, this is where the rubber meets the road.
They actually have one of the best operations structure I've experienced.
It sounds great. I don't know much about them, but I know that you know very, very much about them. But for them to probably take on something like, let's say a nutritionist costs 60 grand a year or something, I don't know, 60, 70 grand. They might have an opportunity to absorb it due to their size, due to their success and being so great in the industry or whatnot. But there's no reimbursement that's coming in for their services. There's no reimbursement for weight counseling, for a nutritionist, and these are the things that always just grind my gears in healthcare. These folks need it so bad. How many folks that are homebound could benefit from? Who can't benefit from nutrition? I mean, I could certainly benefit from a meeting with some people from nutrition. You know, I just feel like when you have people who are homebound and there isn't an automatic allowance for those kind of services to come in, which creates no initiative for folks to hire a nutritionist. In fact, it would probably be very prohibitive to an organization, especially a smaller one, to hire someone like that because it's going to be difficult to afford them, especially if they're just barely breaking even.
Yes, and that's why, like I said, in nonprofit organizations, you'll see strong clinical programs because they're getting grants, they're getting funding donations, right? To augment the cost. And that is also why when you take a look at the financials for nonprofit sectors, you'll see that they're barely breaking even or even in the negative most often. And so that's the challenge that we're dealing with, because and then clients then, our patients are being affected by that, because if they don't have a home health organization that could provide that holistic care, they would have to augment that care in various places. And you know how difficult that is to manage.
Yep.
I don't, I'm not
Yep.
I know for myself personally, when I have multiple doctor's appointments and, medical appointments, it's already, challenging for me
Right,
to navigate that on top of my equally competing priorities in life, right?
Sure.
Then you're a client, a patient that is overwhelmed by all these, care team members that are now involved in your care.
Mhm.
They don't know who is coming in,
Right.
who belongs to where, right?
Right.
They're just, it's just so fragmented that it causes, stress, non-adherence. And they're just like, you know what? I don't even want to deal with this.
Okay. So let's get to something that's positive. Talk to me about NuOps. So you're the op queen is what we're getting here. So talk to us about why you created NuOps and what you're doing to help kind of even this out so that they kind of go north of the break-even point.
Yeah, and so NuOps it happened by happenstance because I had two clients reach out to me and asked, Tien, we just launched our business, our home health business, and we need help because we went with another consulting company. It's been 3 years now, haven't had reimbursement. We need help. And I have a passion for operations after working in operations and seeing, the challenges of and the constant churn that both clinicians and operators are in. And the only reason why I have a knack for operations is, I don't know if you know this, but nursing is my second career. Prior to that, I was in the beauty industry.
Okay.
And I worked for my family business.
Okay.
So by the age of 18, my siblings and I were managing multi-site businesses. So I just had a knack for operations.
Yeah. So in that family business, you worked in operations?
Yeah.
Or, okay.
So then to bridge, because usually in operations, you either have somebody that's really clinical or somebody that's just administrative business. And so you kind of have to be able to marry the two.
Ops is one of the most difficult jobs. I remember when I was doing ops in my company, it was, before I hit CEO, it was unbelievably challenging because it's like, if some of these, like I'd have all these metrics, things have to be at this level, this, that, the other. If it's higher than this, then that means we're like, immediately it's like, oh, we're understaffed or we need to improve efficiency, so blah, blah, blah. And if it's below that, it's like, oh my God, we're overstaffed. We're going to have to let somebody go, or else we're going to have to, bring on some more clients, or we have to, there's never a day that you're actually happy and content. Your job is never actually completed in the way a traditional job can be done, where you have to have X done by the end of the day. You do that, you're accomplished. With ops, the variables never stop.
It's dynamic. It reminds me of being, it really reminds me of being in an acute sector setting where you're monitoring all these, values.
Right.
And it's dynamic, right? Because things shift and change, all these variables, and some things you can control, some things you can't. And the metrics is kind of like a barometer for us to gauge where we're trending. And really a good operator should look at the metrics and understand exactly why the numbers are the way it is. If they don't, we drill into it to determine, what's the cause and how do we solve for it. Okay. So in terms of the operations piece, I just had a knack for it. And but it is, like you said, dynamic. It's not,
you have to be great with stress management. You have to.
Yeah. And I think one of the biggest lessons I've learned is how do you communicate the goals together in an organization and not just keep it within administration, right? And not just keep any challenges in just field ops. We have to really communicate as a whole. What are the objectives? What's the goal in an organization? And communicating the goals, communicating the vision, communicating barriers so that we're all on the same page. And that's one of the trends I've noticed in working with various organizations is that lack of communication of either change initiatives or change management.
Okay.
Right. And so the reason why I established NuOps is I have a passion to stabilize the infrastructure and put in strong infrastructures and processes. which then leads to stronger outcomes, right? Which allows us the ability to then renegotiate payer rates, because you're saying here's evidence that we are doing the work effectively.
Okay. Now, this is going to be a softball, just because of what I've learned from you so far. A lot of groups, whether they're consulting groups or others, they have kind of like this one size fits all. This is what we bring to the table. I imagine when I ask you if you custom tailor your services to the client, it's going to be a resounding yes. That's like the whole point, right?
Well, we discussed earlier that there are certain frameworks that's just kind of like foundation of a house, right? The foundation is really critical. The framework is critical. So we want to make sure that the infrastructure for that framework is strong, especially in remote operations, because everything is remote. You have to make
and
sure
if it's not, you start there.
Yes.
Got it. Okay.
You have to start there.
Yeah.
You have to start there.
Because it doesn't matter what if you're building on sand, it's going to fall no matter what you do.
Absolutely.
Okay.
And then once the infrastructure is built, then you can tailor the process to the individual niche of that industry.
Got it. Okay.
Okay, because every industry has its particular, same departments, such as intake, right? ClinOps, quality, billing.
Yeah.
Right.
Yeah.
So those are standard.
Right.
But then you tailor it to the organization based on really what programs.
This is a startup. They need to be focused on this. This is more important right now than that. And later that might be more important than this, but this is where we are now.
There's certain phases in the business development that need certain reinforcement, right? And so my passion and my goal is to help organizations. How do I impact as many organizations as possible? How do I support as many organizations as possible, right? Which in turns impact care quality or care outcomes from a systemic level.
Right.
Now, I learned that it doesn't matter if you stabilize an organization, if you don't continue to monitor and reinforce the infrastructures or processes, it starts to collapse once I leave, right?
Right. So how do you prevent that from being a problem?
So that's why I established NuOps.
Okay.
Because I was like, well, I don't want to stay at one organization for 10 years because then I'm not really I'm not making most impact.
Okay.
Right.
Yep.
So then, and then things just aligned because I had 2 clients reach out to me and say, hey, we're struggling with this. And then I was like, okay, well, this is a good opportunity to launch, to launch our company. And that's what we did.
So you launched NuOps, you take on a few clients. Congratulations, by the way.
Thank you.
I know you and your team who I met earlier. We're very excited about this stuff. So you get these new first clients, they have certain needs. The point is now that you're going to address these needs, but you're with them.
Yes.
And how?
We're pretty much, they're outsourcing operations to us.
Yes.
Entirely. So that's what we do is we manage end-to-end operations for startup clients.
Okay.
We even manage interim operations for, let's say, organizations that's already established, but they need interim support, or they're going through some sort of operational challenge. They need that reinforcement.
Yeah.
So we provide a team-based model, team approach, because usually if you're hiring just one person to manage it, it's difficult to get it kind of
you need
stabilized.
Some people who are experts of different.
Think of it as like an ICU team, right?
Yeah.
So somebody's in a critical condition. You're not going to just send one person. You got to send a whole team
that's
out
a good
there
example.
to address the situation. And the faster we do it,
the
less churn that's going to be. There's not be.
And you all have your strengths. You guys like form I don't know if you know about Voltron, but it's just like you know Voltron?
Yes.
So that's like you have your folks who all can come in with their different expertise and just take care of things as a team. So that's really cool. But God, the more I learn about home health, the more I am really needing more. Now I don't know why you have champagne just in your house all the time. But that's interesting. Well, how about this? You think we should meet the team?
Well, where are we at in time?
I don't know. I have no idea. I don't know what I'm doing with this thing. 11:55, I think, is what we got. Let's see. Let's check this. Yeah, 11:55.
Okay, so let me just bring the
You
team
want to go get
over.
them? Because
Yeah.
you guys all live in this house, right? Is that how that
Yes,
works?
we work out of. Yeah,
You
so-
guys are a little too close, if you ask me, but you know.
Well, let me tell you this. I think it's important to have a strong team. It's just like, with any sport, this is like, you require a team. It's
Yeah.
a team effort, collaboration, right? So even if you have a strong player, like for example, Kobe or Jordan, whatever, you still need a strong team to support you. And I've got the best team.
Yeah. Oh, I can hear them coming down now. Here come all the elements of Voltron. All right. Do you want to introduce them? These are your people, right?
Sure.
See, you guys can see here if you're in the shot, the camera's over there, just so you know. This is the first time ever having like multiple people on the air.
So I've got Ray here. He is a registered nurse. He's helping me oversee operations and leading strategic initiatives.
Now, how much does she micromanage you since she's the operations person in your operations?
No, she gives me plenty of leeway. She's great to work with.
Good. I mean, it's a transition. Going from COO to CEO is making sure those roles are clearly defined and letting people breathe. It's a huge. It's not easy.
Well, you want to have a team that you can trust, right? And the team that I have, we're learning together. We're learning together, but also they can execute. I've worked with them in multiple projects, and that's the most important is, can you execute? There's all these initiatives and plans and strategies, all comes down to execution.
Right. Yeah. Like I have no worries right now with my staff back in West Bridgewater holding down the fort because I have my officers I know are kicking butt.
And you're able to, do other things that you're interested in too. So, okay, then I've got Mary Westfall. She is our Chief Nursing Officer.
Okay.
She has been in the industry for
17 years.
17 years. Yeah, in home health and
like specifically in home health for 17. Wow.
I've been a nurse for 30 years.
Wow. Well, I've learned a lot about home health today. I don't know if were you guys watching upstairs?
Yeah.
Yeah. It's wow. I am not looking to change places with you. All right. We got Cheryl.
Cheryl Fisher is our Chief Administrative Officer, and she's also been in industry for a super long time.
Yeah, Cheryl and I used to work together back with.
And that's how I met you.
That's right. That's how we met. Yeah, back in the Holy Family days, which was 10 years ago, probably at least 10 years ago. That's one of the things I love about like Boston healthcare is that it like when I first got into the industry, it seemed impossible to understand and grasp everything that was going on. And then the more people you meet, all of a sudden, at some point, it starts feeling a lot smaller. And it's like, oh, here's this person. Now I know these people. Oh, yeah, blah, blah, blah. You just end up interacting with so many people in the industry. It's just, I don't know. It's interesting. Sorry. Continue.
And then we've got Amber Johnson. She is our Chief Clinical Officer.
Okay.
Wound certified. And she is killer in implementations.
Okay. Implementations of what?
EMR systems, electronic.
Oh, this is our IT tech source?
Oh yeah, she's we deemed her as tier 2 level support.
Sounds good. This gentleman?
Ryan Mormon, he is our Chief Compliance Officer.
Oh.
Nice to meet you.
Chief Compliance. Yeah. Oh, compliance. Yikes.
So Ryan is a registered nurse, but he also has his
that's gonna be huge too,
degree.
because I imagine like in home health, like I keep on covering my face. On the home health side of things, I mean, compliance has got to be an extremely challenging place to be in because like when we opened up, and not that I like to bring up the idea of bad actors, but if somebody was going to do something like say that somebody had more of an acute situation than they did so that they could get a higher reimbursement like we were talking about, or somebody was saying that they saw more patients than they did so they could hit that threshold or whatever. I mean, that's got to be just tough. Like, how do you monitor? How do you tell when something isn't legit? And I mean, this is also an extremely regulated field too. I mean, maybe not as much as like the nursing facilities, but it's pretty damn regulated.
It's more risky, I think.
Is it?
Yeah.
You think? Yeah.
Yeah.
That's got to be.
God. But we're really lucky to have Ryan because he also, not only is he a nurse, but he has his law degree too. And he actually was on the other side of the team. You want to talk more about that, Ryan?
Yes.
Oh, maybe come closer since, there you go.
Do I just hold it?
Yeah, that little gray spot
Ryan.
is,
Okay.
that's your mic, yeah.
So yeah, I'm a licensed attorney in Massachusetts.
Okay.
And I worked at the Department of Public Health
Wow.
in the Division of Health Professions Licensure. So prosecuting healthcare providers for doing things that maybe they shouldn't have, usually narcotics diversion.
Yeah. But God, you can't have a lot of fans, right? Don't a lot of people like?
No, nobody likes DPH.
No. I mean, then what is it like working for someone that just throws you on a live stream without any?
I'm used to it by now. I've known Tien for a little while.
That's what I've got. Yeah. I feel like this is. Do we have the whole team in this shot? No, almost. We got me. Oh wait, the camera's over there. Anyway, this is the core right here. This is we were describing. I was describing you guys as Voltron. You know Voltron?
Yes.
Okay, like that. You guys all form up and have your own expertise that you guys deliver to help out. So, I mean, you can just feel. I'm sure the people at home are feeling like the strength of your team here because you guys are all together and you guys all live here, right? Is that?
Yes, we all live in our basement.
Yeah. We just popped in from doing the landscaping.
That's great. I mean,
maximizing their productivity.
I think having a team like this, getting it to like, I wish there were folks like you guys, like a group like this, starting up in so many of like the very vulnerable fields. I mean, it's great that you guys are here in home health because it's getting more challenging. We were talking before too, there's a new regulation that just came in that makes it so these OASIS forms that we talked about in the beginning are now required for not just Medicare and Medicaid, but also for all private insurers, even self-pay. So, and it's more administration. And you know how much they're reimbursing for that? Zero. Yeah. The usual, the hey, do more work for us. It's required, or we're going to shut you down, and we pay you nothing. Awesome. So I don't envy, but I think it's such a need for you guys. So, you know, I'm sure folks at home are thinking this, but just on their behalf and my own, thank you guys very much for what you guys are doing. It's great to know that there's teams like you out there. And I think that a lot of people need to know who you guys are. I know you guys got a full load of work right now, but if you haven't gone to NuOps, what's the website? It's nuops.co.
Yep.
Is it all one word? Is there a hyphen? Is it
just NuOps.co?
NuOps.co. And then you can get on the waiting list, I guess. You guys have to start a waiting list, I think. So
every 6 months
every 6 months we'll reevaluate for capacity. Currently we're at capacity. We're so grateful to all of the organizations that have trusted in us to support their operations. But every 6 months we'll evaluate to open up for new prospects.
Okay, perfect. And thank you very much for coming on Tim Talk.
Thank you, Tim, for having us.
Thank you all.
Thank you, Tim.
All right, we'll see. We'll see you guys at the next one next week. What do we have next week? Next week is Labor Day, so we're doing a relax. We're not going to do a super aggressive. Although this wasn't really aggressive. We didn't go through the grinder much, but I would say so. Next week we have Kim Brewer, who has recently exited healthcare to get into, but she was one of the biggest names in Massachusetts pediatrics. She worked in the Northampton County, which many people don't know is the largest concentration in the country of LGBT folks. And she worked in pediatrics during the time where everything was emerging from the trans movement, understanding singular pronouns, non-binary, pansexual, all this stuff was coming out. She was at ground zero in pediatrics. Imagine what that was like. She has all sorts of war stories. She had a huge group practice with dozens of clinicians and staff to manage. She's going to have some we're just going to do some relaxing war stories. And so we look forward. We'll be in Springfield. We'll be in Springfield, Massachusetts next week. So make sure you tune in. Thank you, guys.
Thank you.
Bye-bye.